about disparities between morphology and immunophenotyping in the diagnosis of MCL. Dr. غسان احمد graduated from College in 1992. He got the fellowship of Iraqi for Clinical Society on Pathology at 2006. Now he is consultant macropathologist doctor in
Today we'll discuss disparities in morphology and immunophenotyping in mental health. I will show you 3 cases that appeared in my graduate lab. Each case was different morphology. Let's take a short summary about mental health. Of course, you all know it's a non-Hodgkin lymphoma. It's about 2% صوت لازم أقرأ يعني. Okay. Is that okay? It's characterized by involvement of lymph nodes in lean blood, bone marrow, tonsils, liver, gastrointestinal tract. Mantle cell lymphoma may enter brain, lung, and spinal cord. The prevalence in the whites is higher than in the blacks. The male to female ratio is 4 to 1. The age ranges between 35 to 85. And really here in Iraq we are seeing the lower age group. The median is 60 years with short remission duration. Survival to 4 to 5 years, overall survival. And there is no causative factor for it. Clinical features, as all lymphomas, there is loss of appetite, fever, night sweating, nausea, vomiting, pressure, pain, disease complication, disease progression, includes cytopenia, gastrointestinal pulmonary sinus complications, and leukocytosis. Diagnosis is based on lymph node and or bone marrow biopsy. It's the best diagnosis for lymphoma. Of course, as hematopathologist, we must have a share of lymphoma. So, we can take it from the blood film, if it is in leukemic phase, to become central cystic lymphocytes. The mantle cell lymphoma is characterized by expansion of the dorsal mantle zone that surrounds the lymph node germinal center by small to medium atypical lymphocytes. The most important thing for diagnosis of mantle cell lymphoma is the translocation 1114, okay, which gives overexpression to cyclin D1, which is responsible for mitosis. The differential diagnosis of mantle cell lymphoma includes small lymphocytic lymphoma, which is CLL, marginal zone lymphoma, and molecular lymphoma. Well, let's talk about our topic, morphology. Mantle cell lymphoma. In morphology, we may see it in 3 different shapes or types. The first one resembles identically CLL. Small mature lymphocytes with many smear cells, and I will show you a slide about this. The second is a classical lymphoma, heterogeneous cells, and I will show you a case. And also the last one, it resembles ALL, acute leukemia, the blastoid variant. I think a lot of the students of the board know it. I showed you this case. So we have 3 categories or 3 morphology in mantle cell lymphoma. It's very difficult to diagnose morphologically alone. So please don't be heroes. So we spoke about morphology. Of course, after splenectomy, white blood cell falls and the progression of mantle cell lymphoma into Burkitt lymphoma or blastoid variant. talk about the immunophenotype. Characteristic immunophenotype is the B cell markers, CD19, 20, 22, 24, CD79A. Also, a T marker, CD5, CD79B, and CD7, BCL2. These are normally present in mantle cell lymphoma. Lack of CD10, CD11C, CD103, and BCL6. Remember CD10, but that will come in one of the cases. Put it in your mind, CD10. Expression of CD20 is strong. Failure to express CD5 in 10 to 15% of the cases. CD23 is expressed up to half of the patient. 23, half of the patient. Put it in your mind. But it's weak. It's radially detected by flow better than immunohistochemistry. CD25 is not expressed, usually not expressed. Put this marker in your mind also. The cases that will come shows positivity of these markers. CD38 is expressed more than 20% of the cells in the majority of the patient, correlates with worse prognosis as in CLL. And CD43 is very associated to be weak or negative. CD45 is strong, it has a strong expression. Apparent expressions also are present, either T, which is 2 or 7, and maybe myeloid like CD13 and CD33, and we will see an apparent expression of CD13 in one of the cases. Surface membrane immunoglobulins is moderately strongly expressed. It's usually IgM with or without IgE. The cells of mantle cell lymphoma usually express nucleocytine D1. Let's talk about the nucleocytine D1 because some of my colleagues suggest that if nucleocytine D1 is negative, the case is not mantle cell lymphoma. This is wrong. The detection of nucleocytine D1 by flow cytometry may be neither very sensitive, because in one of the studies positive in only 2/3 of the patient. So 33% of the patients are negative, of mantle cell patients. Not totally specific. Why? Because about 1/5 of the patients of CLL are positive for cyclin D1. So in CLL it may be positive, and in mantle cell lymphoma may be negative. So it's not a rule. Please put it in your mind, it's not a rule. Problems and pitfalls. Diagnosis for cytological features is difficult. As we mentioned before, it may come as an acute lymphocytic leukemia, or it may come as a classical lymphoma case, or it may come as a CLL. These are the problems in morphology with mantle cell lymphoma. So, to be correct in our diagnosis, we should do immunophenotyping. Let's see the cases and see the variation in morphology. The first case, 63-year-old female with hepatocytomegaly and lymphadenopathy. Morphology report showed heterogeneous group of cells, small mature-looking lymphocyte, and more larger cells that constitute 95% with smear cells. Flow cytometry report showed cluster of cells in the lymphocyte region, 98% of the cells were positive for 19, 20, 23. Here's 23, as I told you before. 17, 9B, 10 also, 13, 8, and 5, and 25 also, and Qaa'a. Really, this combination of positive markers was a dilemma for me. So I searched, this is a real case. And I found this note in one of the textbooks. That CD10 antigen has been found positive occasionally and is usually co-expressed with 25 and 38. Thank God, as was the case. Those three markers are positive also in the case. So, was diagnosed as mental cell lymphoma. Here this is morphology. This case was referred to me as a case of CLL. And really when I see it here, it's a CLL. With the small mature looking and smear cells. We all know. Here's the smear cells. These are small mature looking. There may be a bit of heterogeneity, but it's not that obvious. These are the markers that are positive. And this is the dotted dots for the case. Okay. Let's go to base 2. Base 2, 49-year-old male. Of course, some of the requests are without any clinical notes or nothing. Just a name. Let me tell you something that we last week. A request from a senior, and the request paper was written with flow cytometry. Sorry, blood for flow cytometry. Yes. And the other line, acidic fluid, flow cytometry. The same paper. So what can you understand from this? Shall I do all the markers? The patient will kill me if I don't know the price. Okay. So, as usual, no clinical notes. Here, in the morphology, our second case was a really typical lymphoma case. Abnormal looking heterogeneous group of cells, small mature looking lymphocyte, larger cells that are nuclear. The flow report after a done rating with 45 or 90 or of the cells were lymphocyte, and positive markers was 19, 20, 22, 5, 79, 80. Negative was 38, 10, 25, and 20. Here is the second phase. This is the head of the... As you see here, it's heterogeneous group of cells, small mature looking and larger cells, abundant cells. These are the markers, positive markers. This is the dot for the case. Let's come to case 3. Case 3 was really unfortunate. Came to me as patient 70-year-old man, no clinical notes, and the request was for ILL panel, acute opinion panel. Because I was in a hurry, work in the private lab doesn't exceed 3 to 4 hours. I have procedure for staging. I didn't see the slide. And I ran away and stated with a panel of acute leukemia. The results were not negative except in anemia. I returned, I stayed the slide, saw it, and I returned and did a panel for LPD. And the results showed me that it was not acute leukemia, it was a case of mantle cell lymphoma. As you can see, morphology, presence of abnormal looking heterogeneous group of cells with high NC ratio, convoluted nucleus, 84% of the cranial dominant formation. Yeah, those cytometry reports. Thank you. normal cells or lymphoid cells was 87% of the cells. A gate was done on 45, another gate was done on 19. And of this gate, 76% of the cells of the original gate was. The importance of doing gate on 45, then gate on 19, that when we gate on 45, CD 45, all the abnormal groups will come together. So, if we don't gate on 45, some of the lymphocytes or lymphoid cells will be lost. Maybe if it's higher, it will be lost in the monocytic region, or if it's smaller, it will be lost in the peripheral region. We must gate with 45, and then if we can get with CD19. The cells were positive for 19, 22, and CD13. CD13, CD5, 79B, and negative for 33, 34, 14, 3, 23. And this case, which was sent to me as acute leukemia, and CD13 was positive with radio challenge. Of course, if you remember, as I mentioned before, CD13 and CD33 may be apparent in mantle cell lymphoma. But this is an apparent mantle cell lymphoma. All the B lymphocyte markers are present. And this is the case as you see. Either is it obvious? Then nuclei with opening chromatine. It really looks like acute leukemia in morphology. This is another slide. Of course, the resolution is better by the microscope. This is the positivity of cases. And thank you very much.
We will start discussion from the last subject, but of course not the least, with Dr. غسان, if there is any question for him.
Thank you, Dr. غسان, for the nice presentation. But we see cases, clinic case, mental cell lymphoma and plastic case. Usually presentation not of leukemia, and immunophenotyping presentation not of that of leukemia, but that of lymphoma. So the mature lymphocyte phenotypes will be present in all of this class, like in morphology. But immunophenotyping it is more mature. So in the leukemia panel, we will not reach to a diagnosis. We have to do a lymphoma panel, and we will see that there is GABA or Lambda or 79B or CD20, CD200 usually negative, which can a good clue for mental cell. So my point is that patient with mental cell lymphoma in plastic, if we suspect the case, whether it is in plastic form or it is we have to do lymphoma panel after doing the leukemia panel and not achieve good diagnosis. Thank you very much.
Dr. Thank you for this question. I don't know if you really heard me. The case was referred to me as acute leukemia, and I did a panel to acute leukemia. And when I saw the results, I returned and do another panel for LPD. So the referral was for acute leukemia.
For the leukemic presentation of this case. Leukemic morphology.
I don't think so. It may appear and it may not appear. Is there any correlation with morphology?
I didn't treat anything like this. It may appear in classical case. It may appear in a case that the result was CLL. Yeah, I understand your answer. We appear in any morphology. That's why I'm confined to the last paper. And then should be protected. في منهم ما اللي يقبل بالموتين. وواحد شاطر.
الدرس بإذن الله